Well, U.S. partner trial, which is an IDE trial, is a multi-center randomized trial that is comparing the Sapien Edwards valve to standard treatment in patients with critical aortic stenosis who are at high risk. And it's a little bit confusing, so I'll try to sort it out for you as best I can. The cohort A are patients who are high risk, which means their Society of Thoracic Surgery risk score is over 10%, which would correlate with their mortality rate. And those patients are randomly assigned between transfemoral or transapical aortic valve replacement versus surgery. And the reason that they would receive a transapical procedure is if they have poor access through their groin. So high risk but operable patients, 50-50 get the transcatheter valve and 50% get surgery. Cohort B is a group of patients who are at such high risk that they're considered inoperable or have a combined mortality and morbidity rate greater than 50%. In those cases, the patients have a randomization 1-to-1 between transcatheter valve and medical therapy, which can include balloon aortic valvuloplasty. So there's basically four big arms to the trial. Cohort A, surgery versus the transcatheter valve. Cohort B, medical therapy versus the transcatheter valve. And we have just finished enrolling both the A and B cohorts in the United States. The primary endpoint is 1 year mortality, and because we've just finished enrollment, we expect it'll be sometime in the fall of 2010 when all the patients are out a year, and then the report would go to the FDA and request for approval. So for the partner trial, we're complete. We're going into now to a continued access mode for the next few months, where we'll be able to continue to treat patients, but they won't be a part of the original two cohorts. The next plan, however, is to move into partner 2, which will likely be a better valve, a smaller catheter to go into the groin, but bovine pericardial leaflets just the same, and probably a redesigned stent, which allows us to get into a smaller delivery system. There's also a continued number of studies going on in Europe, which are the SOURCE registry, which is a post-market registry where they're tracking all the patients receiving the valve in Europe. So that's where we are with partner. Still a ways off in the U.S. for commercialization, but really a very powerful trial, probably the most rigorous valve trial ever designed, and to be submitted to the FDA. Well, timing is everything. Clearly, with the core valve not quite in human trials yet, the challenges I think in the United States with core valve will be we've never had a valve approved in this country that was made of porcine pericardium, and so that's an issue. And the second issue is nitinol is not one of the more popular constituents of any device for the FDA because of prior history of breakage due to fatigue. So first of all, they're going to have to make a very compelling case that the design is such that it is safe, and the results from Europe would suggest that it's not only feasible, but it has efficacy. And the last I heard that the human trials will probably begin sometime in 2010. We don't know yet how many patients the FDA will ask for the core valve, and what kind of follow-up they're going to require due to the new materials that are involved in that device. The other issue you mentioned is questions about timing. Clearly, the staggering of these various trials is critical in terms of enrollment strategies. Right now, we will probably be in another randomized trial with the Sapien valve in 2010. So if core valve is hopes to compete at the same time when Edwards has a randomized trial, they really need to get going sometime in 2010. I think that the commercialization of the Sapien valve that we're currently using is probably no sooner than 2012, but core valve may be out 2013 or 2014. So it's a big challenge, obviously, to recruit patients to a randomized trial when you already have a commercially available valve in the clinic. So it is a challenge for the companies, and Medtronic has certainly got some high hurdles ahead. Well, heart block is an important issue for both valves, really. But I think the reports have been pretty clear that core valve has a higher incidence of heart block acutely and conduction abnormalities. The stent is much longer, and the skirt moves well into the left ventricular outflow tract in an area where the bundle of His is present, and the pressure from the valve may quite likely causing heart block. Now, we put a lot of pacemakers in our patients after the Sapien valve as well. However, in most cases, our experience has been that these are patients who came in with significant bradycardias or conduction abnormalities already. So we're trying to look a little more carefully at that, but I think everybody feels pretty strongly that there is a higher incidence of heart block in core valve, and it's related to the design of the device. Well, there's a lot of questions about who will be delivering these devices down the road and what kinds of competencies would be required. Clearly, right now it's a very challenging device and a challenging group of patients, and the device is going to be easier, and there's the procedural development as well as the technical developments of the device are going to be helpful so that the rollout into the community hospitals will clearly be inevitable. I think that the other question is how much will the surgeons be involved versus cardiologists. Clearly, cardiologists have a lot of the catheter skills as a part of their standard training in interventional cardiology, whereas in surgeons' backgrounds it's less so, although the young cardiac surgeons these days are getting a lot of training in endovascular techniques. So my feeling is that both surgeons and cardiologists will be involved, and if they have appropriate training and credentialing, will be placing the devices transfemorally or transapically, or now we're seeing an increase in growth in the subclavian approach. So both will be in the game, and both will be qualified. I believe both of the boards will have standards and guidelines, and the hospitals will have to develop their own credentialing guidelines in concert with those. By far one of the most exciting times in the treatment of patients with cardiac disease. All these devices are revolutionary. We're just talking today mostly about the first two that are coming down the pike in the United States, but there are literally dozens of companies that are developing very, very novel technologies for aortic valve replacement. Right now we're focusing on calcific degenerative aortic stenosis, but we need valves for aortic insufficiency. These valves, we didn't discuss earlier, but these valves have been placed inside of surgically placed prosthetic valves which have degenerated, so that's a fantastic advance for us. And also the need to move into the mitral position, either as a valve replacement or a valve repair. Clearly, the valves are receiving tremendous amount of attention from industry. And to me, I think we all know about Willie Sutton, the famous bank robber, when they asked him why was he robbing banks, because that's where the money was. That's what's going on with in the valve business. There is a tremendous amount of investment in this space because with the analysis of the population, in particular the aging population in this country and in the Western world, the number of patients who would be candidates for a percutaneous or less invasive aortic valve and mitral valve is growing in an exponential rate. So there's going to be a lot of activity occurring very quickly. The technology is going to be fantastically improved upon in the next 3 to 5 years. So I think this is going to be a very exciting time for the treatment of valvular heart disease, both for the physicians but also for the patients who will enjoy a much less invasive and less painful recovery from their surgery.